So, sir. So
Okay.
good day, everybody. This is Dr. Obiora Maludum. He's a structural interventional cardiologist in the US at Blount Memorial Hospital, Tennessee. And he will be giving us a lecture today on management of conduction abnormalities following TAVR. So we'll encourage you to kindly listen, and we look forward to a very good learning experience from you, sir. Welcome, sir.
Thank you. I think I need to share my screen so you guys can see the slides.
Yes.
All right, so I'm going to be talking about TAVR-related conduction abnormalities, the incidence, clinical impact, and management, and I have nothing to disclose. So like I said, TAVR procedure, the device that we use for the procedures, the mechanism of deployment and everything has actually improved over the years. And so we found out that majority of the complications that we have after TAVR have markedly reduced, like vascular complication, paravalvular leak, and all that. They have all basically improved. But unfortunately, the conduction disturbances that we have during TAVR has not actually improved that much. Owing one to the proximity of the conduction system to the aortic valve where we deploy the TAVR valves. And majority of the conduction abnormality, we have a high degree AV block or other significant bradyarrhythmia that require permanent pacemaker placement. We also do have a new left bundle branch block that can occur after TAVR. The reason why we have this high incidence of conduction abnormality, also apart from the close proximity of the anatomy of the conduction system and the aortic valve, is because majority of the patients who come for this procedure with severe symptomatic aortic stenosis also do have problem with the conduction system, because just imagine those calcification that we see in the aortic valve can also affect the conduction system. So that is why also majority of them come with comorbid conduction system ab initio prior to having the procedure. Even when we do the procedure, they also may develop some conduction abnormality. So I wanted to show us this slide here to let us know, for those of us that will still remember our anatomy here, to know that we know that the AV node is just at the lower part of the interatrial septum. And then if you remember your congenital, one of the things we learn about in congenital is that the tricuspid valve, as opposed to the mitral valve, is more apically displaced. So you have that part of the interventricular septum that connects the left ventricle with the right atrium. And in the uppermost part of that is the membranous septum, and that is where the bundle of His actually penetrates into and then goes down and then divides into the right bundle and the left bundle. The left bundle is more superficial in the subendocardium more than the right bundle. So, and it's also closer to the aortic valve, and that also gives us more new left bundle branch block after TAVR. And also those of us that are also aware, this slide will also show you where the bundle of His is in that membranous septum. So this part here, in that thin part is where the membranous septum is. So with that being close to the aortic valve, there's a risk of bundle branch problem after TAVR. And then also those of us who are more into EP will remember the triangle of Koch, and that also has to do with where the coronary sinus level is with the tendon of Todaro and also the septal attachment of the tricuspid valve. So just beneath the apex of that triangle is where the AV node comes out and then pierces the membranous septum as a bundle of His. And those places are also in close proximity to the aortic valve. So what are the predictors based on previous studies that have been done, predictors of conduction disturbances? One major important thing is the depth of the insertion of the TAVR valve. So the more deep into the ventricle you place the TAVR valve, the more likelihood you're going to have a conduction abnormality, especially a left bundle branch block. And this you can see that in this study that was published by Pisa in 2008, when the depth of implantation of the TAVR valve is more, then new onset left bundle branch block is going to be more. The other clinical demographic factors that have been shown to increase the risk of the conduction abnormalities, sex, female patients are more at risk of having this conduction abnormality because they more of less have a more elliptical left ventricular outflow tract. And then advanced age also come with calcification and also calcification of the conduction system. Diabetes, we know CAD and also people who have had a prior cabbage. Then also the anatomic factors is, like I said, the membranous septum length. So the longer the length of the membranous septum, the more likelihood of damaging the conduction system. And also if you have a high calcium burden, and if the location is also close to that place, and then it may lead to more increase in conduction abnormality or even permanent pacemaker need. And then the annulus or the LVOT area. So what we try to do is that when we size the valve, we want to make sure that the valve size is not bigger than the annulus or the LVOT area. And like I said, the LVOT ellipticity can also be a contributing factor to development of this conduction abnormality. One other important thing when you look at the EKG, and we should always be mindful of, is if a patient has a pre-existing right bundle branch block before this TAVR procedure, we consider those patients are increased risk, higher risk than normal people. Because like I said, if they already had a pre-existing right bundle branch block, and then you put a TAVR where they likely may have left bundle branch block, then that portends more danger. And we're going to look more into the results of some studies that were done. Then first degree AV block is also one of the factors we look at for, and usually also prolonged QRS, if the absolute number and also if the difference after the procedure is more than 20 milliseconds. We already looked at the TAVR depth implantation. We talked about the sizing. And also another consideration is if you anticipate you're going to do a pre or post dilation after placing the TAVR. Because sometimes, because of the amount of calcium that is in the aortic valve area, sometimes we may elect to do pre-dilation first before we put the valve. And also sometimes when we put the valve and we see there's a lot of paravalvular leak, we may also do a post-dilation. So those dilation also would increase your risk of developing a conduction abnormality. So one of the mechanisms of this conduction abnormality is a direct compression, like we talked about, because the aortic valve and the conduction system are in close proximity. So direct compression is one of them. Then because of the deployment of the valve, you can have hemorrhage or hematoma around that area. Then also ischemic injury and inflammation. But we noticed that over some days that the hemorrhage and inflammation may improve over time. And if they do improve, then sometimes the conduction abnormality that we have, either left bundle branch block, may also improve. So that is why sometimes we don't rush to put a permanent pacemaker. We do usually put a temporary pacemaker, which I'm going to talk about. So basically, in terms of the timing of permanent pacemaker, we've noticed based on the TVT registry. So usually all the people who do TAVR here in America, we put all our information into the TVT registry. So with that, we looked at this publication that was done, and from 2013 to 2018, we noticed that the incidence or the number of patients who had a permanent pacemaker has relatively remained the same, almost around between 10 to 15% over the years. But you notice that for the orange one, that the people who now got a pacemaker after discharge has also increased over those time. So we will look to see if this is really necessary that we put a lot of pacemaker in this patient. So this slide here is showing you that the timing of permanent pacemaker placing, the majority of the patients get their permanent pacemaker within 2 days. That's 48 hours. Some do eventually get it later on, but majority and the most amount of patients getting within the first 48 hours. So for the next slide, I just wanted to highlight that the majority of the new left bundle branch block are transient. So, and up to 40% of them resolve by the time the patient is discharged. And even when they are discharged, the remaining 60%, about 30 to 50% of them resolve by 30 days. So pacemaker is not really needed in some of these patients if they are stable. And we know that left bundle branch block can also be stable and asymptomatic and do not need a permanent pacemaker placement. But like I said, if a patient already had a pre-existing right bundle branch block and then now develop a new left bundle branch block that is persistent, then those patients will definitely need a pacemaker, permanent pacemaker. So majority of the indication for permanent pacemaker after TAVR, majority is due to high degree of complete heart block. That's where we usually put majority of the pacemaker, almost up to 80% in some studies, followed by sixth sinus syndrome and second degree AV block, second degree type 2 AV block. So the PRICE 3 clinical trial was looked into because some of those patients that we know that got permanent pacemaker, we wanted to look at how many of those patients were eventually pacemaker dependent. And you will see from this slide that when you look at 30 days as opposed to 1 year, that there's a decrease in number of patients who are pacemaker dependent. So meaning that some of those patients who really got the pacemaker may not eventually need the pacemaker. So let's look at the overall incidence of permanent pacemaker after TAVR. So one of the factors to consider, especially like I said, if a patient had a pre-existing right bundle branch block, is to know which of the valve am I going to use more to reduce the incidence of left bundle branch block or significant conduction abnormality. So the core valve has more risk of developing conduction abnormality than need a pacemaker. The rate is about 25% plus or minus, as opposed to the Edwards valve, which is about 6%. So the Edwards valve are safer in terms of conduction abnormality, and the core valve, which are self-expanding valves. So the Edwards valve are balloon expandable. We use the valves are mounted on a balloon, and we use the balloon to expand the valve, but the core valve expand on their own. They are self-expanding. And because of their length, they are longer usually than the Edwards valve. So they have more risk of having a conduction abnormality, about 25%. And we talked about advancement in the TAVR valves that have been going on over the years. And when the first set of TAVR valve, the SAPIEN Partner 1 trial was done, the rate of pacemaker, new pacemaker placement after 30 days is about 6.8%. Then came the SAPIEN 3 valve, which was a modification from the earlier SAPIEN valve, the Edwards valve. So because of the bulky nature of the initial part of that SAPIEN 3, the incidence of pacemaker placement was noted to increase. Then we now got this S3 Ultra, and the incident has come back to around that 6% that it was initially. So looking at the Medtronic valve, like I told you that the incidence of permanent pacemaker placement in Medtronic valve are higher, usually in about 20%. And this also shows us the evolution from the initial Medtronic valve to the Evolute R and then the Evolute Pro. But usually you still see that the permanent pacemaker incidence here is in double digit. So we also have some other valves that we usually don't use most here. I don't know if you guys use it in Europe, Lotus Edge and all that. So this is just to let you know that either way that the incidence is still a bit high in most of these valves. So then let's look at the new onset left bundle branch block. Right, so the incidence of new left bundle branch block in patients after TAVR as opposed to if they had a surgery is 22% overall. Like I said, if you now want to divide it into Medtronic core valve versus SAPIEN valve, you now see the variation. But this is just telling you that overall that you're likely going to have new onset left bundle branch block after TAVR compared to surgery, as noted by Babanti et al. In 2017. So what are the adverse clinical impact at 1 year of TAVR-related conduction disturbances? Because, like I said, the right bundle branch block that was pre-existing is a bad omen for these patients. So we usually take them more seriously. But for patients who develop left bundle branch block without a prior right bundle branch block, studies have shown that the development of that left bundle branch block have varying effect on the patient. So in this meta-analysis that was done by Farrods, they found that if a patient developed a new onset persistent left bundle branch block after 1 year or at 1 year, that they have increased all-cause mortality, increased cardiac mortality, heart failure hospitalization, and also need for permanent pacemaker placement. And then if they eventually got a permanent pacemaker placement, there's also increased all-cause mortality and heart failure hospitalization in these patients. So the next slide is just looking at partner 2 trial, part of the partner 2 trial, which looked at the clinical impact of new onset persistent left bundle branch block in intermediate risk patients, because partner 2 dealt mostly with intermediate risk TAVR patients. So you can see from here that if a patient develops left bundle branch block at discharge, this one is at discharge. Usually when we do the TAVR here in America, if they're very stable, they go home the next day. If they are not that very stable, we keep them longer, maybe 2 or 3 days, and then decide if they need a pacemaker. But if a patient developed left bundle branch block and was discharged, it has been shown that they have also increased all-cause mortality and also increased cardiovascular death. That is death due to cardiovascular causes.
Obiora,
go ahead.
Sorry to disturb. There's a question. There's a question in the chat group that says,
yeah.
Thank you for the great presentation, but any reason why the incidence of pacemaker is higher with the self-expanding valve as compared to the balloon expandable, since one of the risk factors for heart block is pre and post dilatation?
Okay, that's a good question. So, like I said, if I put a picture, maybe I should have put it. If I put a picture, okay. So, can you see the Medtronic core valve?
Yes.
You see how the length is. You compare it to the Edward valve. The Edward valve is shorter, so the Edward valve has a less risk of going to that membranous septum. Remember, we said that the conduction abnormality goes through that membranous septum. So the Edward valve is short. So usually when you put it, it just stays up there. It doesn't get down to the membranous septum. But the core valve, because of the length, usually a lot of them presses on that membranous septum, and that is why. Does that answer the question?
Yeah, I think it does, yeah.
Okay, all right.
Thank you.
Yeah, so the other thing we're going to be looking at for here, sorry, I'm using my phone, so I don't see those questions. So if you see any questions, just highlight it to me. So the other thing we look at for here is new left bundle branch block after TAVR. It's been shown by Irena in 2015 that it's associated with sudden cardiac death. So the reason why I'm bringing this is that some people have made the argument that if a patient develops persistent new onset left bundle branch block, that we should put a pacemaker on them. So this study, and all the studies that I've been telling you about, there's no randomized control trial in any of them, just to point it out here. The majority of them are either through retrospective study or through a cohort prospective study, but none has been randomized. So we kind of use some of these things just to help us. And even in 2020, the American College of Cardiology expert panel just sat down together and decided to give like expert guidance in what we do in these patients. So the development of new onset persistent bundle branch block, left bundle, has been shown to increase sudden cardiac death. And then if the QRS duration in this patient who developed left bundle branch block is more than 160 milliseconds, they are even higher risk of sudden cardiac death. So these are the patients that most of the time we go ahead and put a pacemaker on if their QRS is usually more than 160 milliseconds based on some of these studies that were done. But it's also good to know that in this study, they looked about 3,700 patients, and 57% of them were balloon expandable, while 43 were self-expanding. And then also they also looked at if your EF is lower, you have a higher mortality. So combining the partner 1 and partner 2 analysis for the EF evolution, that's left ventricular ejection fraction evolution, this showed that if a patient developed a new onset left bundle branch block, their EF goes lower over time. And if they got a pacemaker, it also goes lower, but not as lower as just having left bundle branch block without a pacemaker. So this is the argument that some people are making, that if a patient has left bundle branch block and even the QRS is quite wide, that we should put a pacemaker in them. Then come another study that kind of threw everything in the wind and kind of let us know that probably left bundle branch block is not that very bad in some of these patients. So these patients' total population was about 1,020 patients, and they did not have any prior or any hospital permanent pacemaker placement. So they did not have any permanent pacemaker placement before they were even discharged. And they did not have a prior left bundle branch block. So these are patients who developed new onset left bundle branch block after TAVR. And there were about 20% of patients with that, about 212 patients. So this graph here is showing us that even if they have left bundle branch block, that there's no difference in mortality, no difference in hospitalization, no difference in terms of pacemaker at follow. Sorry, actually, they had more pacemaker if they developed left bundle branch block. So those patients had a pacemaker placed in them. But based on the first two slides here, you see that there's no difference in death, there's no difference in heart failure admission. So this kind of threw everything out of the window for us. But like I said, these two studies, none of them is randomized control trial. So what we do most of the time is that if the QRS is quite wide, like 160 and above, we usually go ahead and put a pacemaker in them. Okay, then go ahead.
There's a question here. Thanks for the wonderful lecture. What is the timeline for the persistence left bundle branch after block, after TAVI, and the patient develops complete heart block? How long do you monitor before you decide it's persistent and requires permanent? I think you said 1 year. After 1 year, is it?
Is it left bundle branch block, or you're talking about
left bundle branch block? Left bundle.
Yes. Yeah. But if it's complete heart block, we usually don't wait. So what the most we wait is for 2 days. We wait for 2 days and see if the inflammation and if the hematoma is going to resolve, and then because we put temporary pacemaker, temporary transvenous pacemaker in all these patients, even on the procedure table, we do that, and then we monitor them in the ICU while they still have the temporary pacemaker in some group of patients, which we are going to look into. But we're going to look into that and we'll let you know, so I don't forget. All right, so we talked about incidence of untiming of permanent pacemaker placement post-TAVR. So majority of them you can see here who had a persistent left bundle branch block got theirs in less than 1 month, but even some, even after 2 years, still some got theirs. But you see that the difference here was not statistically significant for 24 months, 12 to 24 months, and also it's on the borderline for 3 to 12 months. So, but majority of them got theirs in less than 1 month, and that was there was no difference in terms of this. We know that permanent pacemaker placement is not without any complication, even though, yes, with the people knowing about how to place it, the complications for permanent pacemaker has reduced, but still, it's good to know that this is not a benign procedure, that you don't just put it unless it is absolutely necessary. If it's not necessary, you don't go ahead to put it. All right, so I got this slide from the ACC panel that started in 2019 and published their recommendation in 2020. So this is what we do for pre-TAVR patients. So if a patient has high-risk features, and they divided these high-risk features here into ECG predictors, procedural features, and CT predictors. So if they have a prior right bundle branch block or they have a first-degree heart block, it shows us that these patients are at increased risk. Or like I said, if they have a self-expanding valve based on what we talked about, or if the prosthesis, the TAVR valve itself is bigger than the LVOT diameter, if they have you're anticipating that you're going to put a low implantation depth, or if they have pre or post deployment balloon valvuloplasty, then they are also at increased risk. Then if they have heavy calcification like we talked about, or if they have actually should be long membranous septum actually, then they would need to be considered as increased risk. So we counsel all these patients and tell them that they have higher risk of needing a pacemaker if they have this increased risk. And then they screen the patient for any prior rhythm abnormalities. Sometimes we do some ambulatory monitoring first to make sure they don't have any indication that would need a pacemaker even before the permanent, before the TAVR procedure. And then one important thing is that if they are on any medication, whether it be beta blocker, that they need for any indication, either for ischemic heart disease or for left ventricular dysfunction, the recommendation is not to stop those medications. If they've been stable on those medications prior to the TAVR, and they have any of these risk factors, they have first-degree heart block, right bundle branch block, recommendation, do not stop them, because if you stop them, something has shown that they do worse if you stop those medications. So continue those medications if the patient has been stable on those medications prior to the TAVR, even if they have the high risk factors, they have right bundle branch block, continue those medications. Then you also need to schedule the TAVR at a time when a physician that is trained in permanent pacemaker placement is available to do a permanent pacemaker placement. But like I said, these days we do temporary pacemakers, so we can even do it and then wait 2 days for permanent pacemaker placement to be done if somebody who is knowledgeable in permanent pacemaker placement is not available. And then we consider heart valve that are less likely to give you heart block. Okay, so this is also part of their recommendation, like I talked about from the scientific expert panel, and they looked at the ECGs and risk factors, and if there's no ECG changes, no pre-existing right bundle branch block, then you don't even need a permanent temporary pacemaker. So what we do is, before we start the procedure, we get arterial access, usually sometimes through the common femoral artery. We also get a venous access and put a temporary pacemaker before we put the TAVR. So if a patient did not have any ECG changes after the TAVR and also did not have a pre-existing right bundle branch block, we remove the temporary pacemaker just before the patient leaves the procedure room. If they have some ECG changes or they have a pre-existing right bundle branch block, then we keep the temporary pacemaker for at least 24 hours overnight. And then we see them again the next day, see if they have no further episode, then you can remove the temporary pacemaker. But if they have a need for that, you may consider a permanent pacemaker. Sometimes in some patients who are neither here nor there, we can do also, or they did recommend EP study, and they look at the HV interval, and they usually recommend if it's more than 70 or 75 milliseconds. That's the conduction time from the His bundle to the ventricle. They do that for us, and then the EP guys do it for us. And if it's that much, then they put a permanent pacemaker. Then intra-procedural, like I said, continue the guideline-directed medical therapy if they need it for any reason, either for ischemic heart disease, left ventricular dysfunction. And then of all our patients these days, we put a temporary transvenous pacemaker. And also you need to discuss potential permanent pacemaker placement and obtain a consent before the procedure, because you know the patient is going to be sedated. So you obtain the consent before the procedure. Then if there's no new conduction disturbances, the temporary pacemaker, like I said, can be removed prior to the patient leaving the room. If the patient develops some conduction abnormality that needs the temporary pacemaker to be placed for some time, we put it in for 24 to 48 hours and re-evaluate the patient. If after that 24 to 48 hours, patient still has a need for that permanent pacemaker, we go ahead and recommend permanent pacemaker placement. But patient needs to be monitored, like I said, and then we'll make the decision based on that. I'm not going to waste much time in this slide. Just some people coming up with some cohort predictive value to tell you, oh, if they have a combination of right bundle branch block prior, the membranous septum length and all that. This is just a predictive model, but I'm not going to waste my time into that. All right, so also the MIDAS also looked at the depth according to the membranous septum and also divided them into, if they have a membranous septum that is more than 5 millimeters, they are considered low risk. All right, so the next is the post-TAVR management. So if they have symptomatic bradycardia, high degree of block, complete heart block, they need a permanent pacemaker. We put them before the patient leaves the hospital. If they have a new or progressive or pre-existing conduction disturbances that changes post-procedure, we can also monitor or consider EP study, like I said, or put a permanent pacemaker based on maybe if the left bundle branch block is more than 160 milliseconds. Also, narrow QRS before and after TAVR, EP study is not indicated. And then on discharge, if they do not have any need for primary pacemaker indication, there's no new first degree or second degree AV block, no new bundle branch block, patient can be discharged early. Usually we discharge them the next day if there's no problem. If there is problem, we'll keep them at least for 48 hours. And even when we discharge them, sometimes we put a cardiac monitor on them for at least 14 days. In fact, some people also have gone ahead. Sometimes I've seen some of colleagues who recommended loop recorder for even more than 1 year. So this is something that you need to think about. All right. So we already went through this slide, so I'm not going to go to that. So in terms of what is the value of post-procedure ECG? So because we know that delayed high degree AV block may occur in about 2 to 10% of patients. So some patients may not have that high degree AV block, but may develop it late. And the delayed number there is 48 hours. So any high degree AV block that develops after 48 hours is considered a delay. So that is why even when we see them in the clinic, we like to at least do an EKG on them if they do not have any monitor, because we know that about 2 to 10% may develop high degree AV block after 48 hours in this patient. And if they do have that, then maybe they may need permanent pacemaker placement. And the absolute value and change in the QRS and PR intervals have also been shown to be very important in this patient. All right, so we talked about those patients who had a pre-existing right bundle branch block, and I told you that these patients are one of the highest risk patients. And the reason also, if you look at it critically, is that they already have a right bundle branch block, and then you're going to put a pacemaker that may affect their left bundle. So basically, you're kind of giving them high degree AV block. So these patients are very high risk group, and the baseline right bundle branch block has been associated with mortality after TAVR, as you can see from the first graph and also the second one. So the first one, if they have a right bundle branch block, they have increased mortality. And then the second one is also divided them into if they have prior right bundle branch block or not. So like if they do not have a prior right bundle branch block, then they are almost like most other people. So this is just to show that you could get away with having a prior right bundle branch, left bundle branch block prior to TAVR and be okay. But if you have a prior right bundle branch block, there's usually more, they are more at risk. And then we talked about patients who also had a loop recorder, like we said, they monitored them over years, and this was monitored more than 1 year, and you see the bradyarrhythmia events in this patient is over those years. So in conclusion, conduction abnormalities and disturbances, which include the new left bundle branch block, permanent pacemaker placement, remain a frequent complication of TAVR. And then the TAVR-related conduction disturbances are associated with adverse outcome, including mortality. And then you have to place a careful attention to look at the risk factors and the predictors and see how you can modify them in terms of make sure you get the right size of the TAVR valve. For the LVOT, we use CT scan these days for sizing, but in third world countries, we can also use TEE for doing those if we don't have a CT. But I speak with Edafe a lot, and we have a CT scan now in Africa, so we can do that very well in Africa right away. And then make sure you don't do a depth implantation into the LVOT, and then decide, am I going to use a pre or post dilation ahead of time? And that will help you know. So recent advances in management of conduction disturbances have been explored by Jack, like I said, and then you need to make a careful management of high-risk group patient post-procedure. And then guideline indication for permanent pacemaker implantation is also followed. So whether they are going to have this TAVR or not, if they meet any indication for permanent pacemaker placement, irrespective of TAVR, they need a permanent pacemaker placement. And that is it. So this is people that places I got my slides and then recommendations and everything. Thank you.
Excellent talk, Dr. Obiora. That's fantastic. I've got one question. Sure. It says, are there patients that can only receive the self-expanding valves? Are there self-expanding valves shorter than the Medtronic valves? So if a patient must be on self-expanding valve, how do we limit the risk of complete heart block or left bundle branch block?
All right. So this is a very good question. So what we find out most of the time is that in order to reduce paravalvular leak, if they have a lot of calcium, usually self-expanding valve has been shown to be better in that sense. So some of those patients may benefit more from self-expanding valve. But if you're going to do that, then you try to see if you can do less depth implantation in those patients. But in terms of complication, I want to say at this point that the incidence of bundle conduction abnormality and paravalvular leak are kind of inversely related, because the more you try to get the valve more up towards the aorta, the more likely you're going to have a paravalvular leak. And the more you try to get them more into the ventricle, the more likely you're going to press on that membranous septum and cause conduction abnormality. So, but overall, what we do is that if a patient has a pre-existing right bundle branch block, we usually prefer Edwards valve to the balloon expandable valve. But there's no advantage of one valve over the other in terms of the efficacy of the valve. So if I'm going to go with a patient who is high risk, I go with Edwards valve.
That's a fantastic answer. I had a really simple question. I know some of us are not like doctors, and some of us are not in TAVI implanting centers. So I know a lot of people use, they call the acronym TAVI.
Yes.
And obviously some people also use TAVR, like you were saying.
Yes.
So correct me if I'm wrong, transcatheter aortic valve implantation, or
one is implantation, one is replacement.
Replacement, okay.
But they're the same, yeah. They're the same, it's just semantics. For some people, usually in Europe, use implantation. Or here in America, we use the replacement.
Replacement, brilliant. Thank you. Thank you for that. I think did I have a question? So on average, how long would you expect like a TAVI patient, say, like the reason why you might implant it? Because usually the first point of call, is it like, did they have a valve replacement, like an open heart surgery? Or is it those patients that are quite like feeble and quite old that they will, as proper surgery will be too much for them? So TAVI would be the best option for them. Is that
Yeah, so okay, let me go through the evolution of TAVI or TAVR, right? So when TAVI came in initially, it was for those who are called inoperable, those who are not surgery patients. That's when TAVR came out initially. But over the years, they reduced it to only those who are high risk. So they use what we call STS score, which the surgeons use to determine if a patient is high risk. So if a patient has about 4% or less, they are considered low risk, 4 to 8% or so, they are considered intermediate risk, and then more than 8% is high risk. Then with more evolution, a study was also done like in partner 3 trial and all that. And we have also seen that even low risk patients these days can also have TAVR. So right now, it's now basically depending on, you look at a lot of factors. You look at if a patient will need coronary artery bypass graft at the same time, because if they do, you may consider to just replace their valve surgically and also do the bypass graft for the coronaries at the same time. So the dynamics are changing now, and also right now, I've even seen some young patients even getting TAVR because of the advancement in TAVR procedures. So we do that. And then we also have what we call TAVR valve in valve. So because the initial point is that TAVR valve may not last long, but some studies have now shown that even they are also lasting longer. And even if they have a problem now, you can also do a valve in valve procedure in this patient. So I don't know if I was able to answer your question or.
Yeah, that's answered it. That's excellent. Really, really good. You really know your stuff. Are there any other questions? Dr. Daffy? No questions? How many, okay, so I'll just, how often do you get peri-procedure complications? Like, given that most of your patient groupings are quite critical and things, is that something that do you get, is it a high death rate, for instance? How often do you get complications? And how do you prep the patient during the procedure? Do you put pads on? So I'm really speaking for the physiologist here. So do you put pads on, and obviously you put a temporary pacing wire in, and can you just go a little bit into that for the physiologist, and then basically what rate do you normally pace the pacemaker when you're deploying?
Yeah, good question. So we, like I said, for all the patients, we put a temporary pacemaker because what we don't want is a situation where you're putting the put it ahead of time, place it there, make sure the temporary pacemaker is working, so that if we need it, we just turn it on. So that's one. Also, we put a pads on them in case we need to shock them. We don't want to waste time, so we put a pad on them to do that. And then in terms of what was your question again? I think there's a question I missed.
Yeah. So what's the risk? Like how often?
Yes. So like I said, these days, majority of the complications post TAVR or during TAVR have reduced. In fact, they are almost 1% or less than 1% now, majority. But like I said, the only complication we still get more than others is the conduction abnormality. And because, like I said, we already have a temporary pacemaker, we don't run into emergency, because if anything goes wrong, we turn on the temporary pacemaker and it starts working, and then they can go with that temporary pacemaker into the units, maybe ICU or telemetry floor, whatever you want to put them. So we put that, they have that temporary pacemaker, we monitor them and see if after maybe 24 to 48 hours, if they still need to have a pacemaker implantation, then we can organize for permanent pacemaker reading. But in terms of the other complications, they are almost non-existent. We usually do not even have any patient that because here in America, we still have to have a CT surgeon in the operating room, and just in case of any problem. But of all the times I've had it, we've never had any need for even a CT surgeon going for open heart surgery on a patient, because almost all the complications, the valvular complications, the vascular complications have almost all reduced. They are very, very minimal these days. We hardly ever have them. It's just like I said, once in a while for the permanent pacemaker placement, we need them, especially if they have a pre-existing right bundle branch block.
Oh, fantastic. Any other questions, anyone? So, so TAVI has to be performed in a surgical, it has to be a surgical cardiothoracic cerebrovascular surgery site on the hospital. Okay.
Yeah. So you need based on the recommendation, I need at least one cardiothoracic surgeon in the room while you're doing the procedure. Majority of the time, they don't actually do anything. It's the interventional cardiologist or structural cardiologist that does the procedure itself. But the recommendation here in America is that you need to have a cardiothoracic surgeon in the room while you are doing the procedure, just in case there's an emergency. So we use what we call a hybrid room. Hybrid room is a room where you do your interventional and structural procedure. But if there's need to have an open heart surgery, they will have it there and then. You don't have to move the patient from that room to another room to do the open heart surgery. So the CT surgeon is there. The surgical techs are all there waiting just in case there's any problem. And if you also look at the evolution, even for coronary stenting, when it started initially, we used to have a CT surgeon in the room, but now we don't need CT surgery anymore for coronary stenting. So my thinking is that in the next some years, maybe 5 to 10 years, that we may not even need a CT surgeon in the room when we are doing that procedure, because people would have gotten used to the whole thing. The rate of complication will keep decreasing, and you don't need a CT surgeon in the room. So we use right now a hybrid room that can do both cardiac cath and also do open heart surgery.
Oh, fantastic. Fantastic. I don't know why any new people are not asking questions, because it's really interesting. My last question is, are there any significant difference between the Edwards and the Medtronic valves in terms of costing, in terms of prices?
They're almost.
Do you think, since Dr. Daffy is really thinking about starting this in Nigeria, like, do you think people can afford it, or is there any kind of program to help with this?
Yeah, so I talked with Daffy about this. So because this has not been done in Nigeria, at least I know of. I don't know in Ghana, maybe they have done it in Ghana, I don't know, but in Nigeria it's not been done. So we talked about doing it, and one of the things, limiting factor there is the cost of the valve itself, because it's very, very expensive here, some in the neighborhood of $40,000. So, and you know, some of the patients back home in our country may not be able to afford that. So one of the things we're going to try to do is talking to the to the Medtronic people and Edwards people to see if there is something that they can give us as a charity. In that case, maybe a patient that needs it will not have to pay a lot of money for it. So that's what we're going to be looking into. But our plan is that at least by next year, this procedure should start being done in Nigeria.
Oh, excellent. Any questions, anyone?
Thank you, Dr. Obiora. Thank you very much for the wonderful and elucidating presentation. We really enjoy your presentation, sir.
Thank you very much.
Yes,
I hope I was able to at least answer your questions, and if
you over-answer all the questions. Yes. So, Dr. Julius, Dr. Obiora is our structural interventional cardiology, and we hope that one day, very soon, we'll plan a TAVI in Nigeria with him. As he said, we have not done TAVI in Nigeria. The major reason why it has not been done is because of the cost. If not, we do see patients randomly. Occasionally, we see patients that require.
We've lost you, Dr. Daffy.
Oh, yeah. I think, Julius, you asked one question that I forgot to mention. So most of the time, in fact, all the time for the Edward valve, because it's balloon expandable, we usually do what we call overdrive pacing. You guys know about it, right?
Yes, yes.
Okay.
So, yeah, so we do the overdrive pacing, and sometimes we go up to like 180 beats per minute in terms of the rate for the overdrive pacing. So what that helps us do, and we do it in a very fast and focused way, what that helps us to do is that it kind of makes the heart to go into like a standstill, because we want to deploy the valve when the ventricle is not contracting and opening the native valve in and out, and then blood needs to come out. So that overdrive pacing kind of helps the heart to be in a standstill, so where it's kind of beating so very fast that it doesn't even allow much time for relaxation, for blood to come in and then go out. So it kind of gets into a kind of, if I may use that word, an equilibrium, where the heart is in a standstill, and then we quickly deploy the valve with the balloon expandable. Sometimes we get away with not overdrive pacing for the Edward valve because those are kind of self-expanding. So we sometimes don't do overdrive pacing for those ones. But for Edward's valve, we usually do overdrive pacing.
Excellent.
Okay, so yeah, very good. Dr. Obiora, I have a question. For following up of these patients after TAVI, especially those that have self-expanding valves, is there any risk that maybe months to years after the implant, they may end up having a conduction abnormality? That is one. Then the second question is, if you had a valve that was already deployed before, and the patient come again for another valve to be redeployed, does that increase the risk of conduction abnormality among this group of patients?
Excellent question. Excellent question. So let me start with the second part, where you're talking about like a valve-in-valve procedure, right? So
yes, correct.
If they already had a valve, so that valve is like a method that's already kind of being protective. So we've not noticed any increase in the conduction abnormality in those patients because the first valve is already sitting there and it doesn't allow the second one to impinge on the conduction system. So we've not noticed any increase in those patients with valve-in-valve. Then your first question was, remind me your first question.
Yeah, the first one is especially the self-expanding valve that are longer than the balloon expandable valves.
Yes.
If you follow them up, after you deploy them immediately, there was no conduction abnormality, but you follow them up for months to years.
Yes.
Has there been incident of conduction abnormality among them? Because I have a patient, I'm following up one patient who had TAVI in Europe.
Yes.
So yes, he had a TAVI in Europe and came back to Nigeria. So I've been the one following her up. She's an elderly woman. I've not seen any of this issue. I'm asking all this one because although we have not started, I'm sure.
Right. I think we lost you, but let me answer the question if you guys are hearing me. So basically, if they did not have any prior EKG abnormality before TAVR, and after TAVR they did not have any abnormality, they are unlikely, in medicine you never say never, but they are unlikely to have any conduction abnormality later on, okay? Unless, like I said, some of these conduction abnormalities are age-related. Like as somebody gets older, the conduction system may start getting weaker, and calcium may start impinging on those conduction systems. So they may develop that conduction abnormality, irrespective that they got a TAVR. I don't know if I'm making sense. So
yes,
it means
correct.
that if they did not get a TAVR, that maybe they were supposed to get the conduction abnormality over time with age, but not because they got a TAVR. So if they did not have a prior right bundle branch block, no conduction abnormality prior to the TAVR, and then within that for 8 hours, they did not have any EKG changes whatsoever, then it's unlikely they're going to develop it based on the TAVR. If they develop the conduction abnormality, it's because they were meant to develop it. But if they had prior changes, yes, those people usually may develop a conduction abnormality more than the other first group of people I mentioned.
It's clear. Thank you very much, sir.
Brilliant, brilliant. I've got my last question, and Dr. Bill, this is so good and interesting. That's why we're So, in centers, because I know that you and Dr. Daffy are vascular surgeons as well. You can do peripheral vascular, you can treat peripheral diseases. So you are perfectly suited to do, TAVRs in case of complications with getting
exactly. Because the sheet we use for these TAVR procedures are big sheets, from 11 French to 14 French sheets. So these are big vascular sheet that you have to be knowledgeable in peripheral most of the time to be able to do this without any problem. Because sometimes I've had a case, let me tell you this. So I've had a case where majority of the time we do TAVR through the common femoral artery. That's where we do majority of the TAVR. But we soon can do transcarotid, there's transapical, So there are different other places you can do the TAVR from, but majority, 90% of the cases is through the femoral. So I've had a case where a patient was not a candidate for this other kind of femoral, this kind of route to do the TAVR procedure. And they also have, in both the iliacs, they have significant disease, right? So when we went in, it was difficult to pass the equipment through those iliac disease. So we had to actually, first of all, do iliac stenting on those patients to be able to get access to now be able to pass our equipment to do the TAVR. So it's usually better if you have a good knowledge of
Well, we've lost you there, Dr. Obiora. Hello, Dr. Obiora. All right. No, we've lost him. Right. Okay. It's I think he's done absolutely fantastically well. I think it's a really interesting area. It's been a really exciting presentation that we've all really enjoyed. And I'm sure you guys have all enjoyed it as well.
Yeah.
So I mean, we've done this. Obviously, there was an earlier glitch technically, but I think we've done it for quite a long time. So do you guys want to quickly run through the EGM questions that AJ said last time? I mean, you were given the answers last time anyway. So have you guys got any questions with regards to that?
Elvis.
Elvis, is he still there? Because he had to go away. He said he had to go away.
Okay. Maybe can we take, Julius, can I plead that we take the question next week?
Okay. Okay. Okay.
It's a plead.
Okay. So next week, obviously, we're in Abuja, all being well, God willing.
Yes. So
so
you'll be in Abuja, AJ will be there. You will be there.
Yes.
So Dr. Misapana is presenting.
Oh, is he presenting? Definitely, yeah.
Yes, she's presenting lab bundle branch pacing next week.
Okay. So I was speaking to AJ earlier. So let me stop the recording. I have to reclaimed. I think it's logged out. Let me just. Well, I'm not sure.
Dr. Obiora will give you the right.
Yeah, I'm not sure because he came out, he logged out without ending. So I don't know what's happened there.
Hello, sorry, I don't know what happened. Sorry, can you hear me
It's
now?
all right, Dr. Obiora. Yeah, we can hear you now. We can hear you.
So
yeah.
I don't know when did you guys stop hearing me? So
right at the very end. I think you said everything. So it was right at the very end. And I was saying, I think we're both saying how an excellent, presenter you are. And it was a very interesting topic. Very, very interesting.
Thank you.
Yeah.
Thank you.
And that's all.
Thank you.
Enjoy it.
So, Julius, are you more into device? What are you more into?
So I'm a device physiologist.
Okay.
So I'm the one that obviously we are the guys that implant it, and we do the programming with the consultant, obviously.
Okay.
We do the programming and things. So
Okay.
the center that I used to work in Scotland before I moved to Northampton used to do TAVR. They only did it. They just recently started doing it. So I had a small knowledge of it.
Knowledge of it, yeah.
And that, so it was saving so many lives, so many.
Yeah.
Amazing. Yeah.
Yeah, I have a lot of patients who, before this TAVR process was started, they would not have allowed you to do open heart surgery on them. So, but these days, when I tell them, oh, you have option of having a TAVR, and they will go through your groin,